Well, thank you very much. I think it would be nice to get probably ready for the next live case, but I think we are still working a little bit to get the connection to Leipzig. So that's why we continue here with the next talk, and in a sense of continuing with controversies. I think certainly one of the controversies, or let's say uncertainties, which is out there is whether all DCB are the same. I've seen on one of the slides shown by Peter Ferris, I think it was on the second last, he stated that there seems to be some sort of class effect. Well, at least I think all DCBs are currently using paclitaxel, but I'm not sure if you really can call it a class effect. At least there is, I think, a lot of discussion, and usually you see now a lot of data points put side to side to each other. And we all know that, of course, it's very difficult to make cross comparisons between different studies. That's why I think what the field really needs, if we deal with new devices, is that we go for head-to-head comparisons. It's difficult to conduct in the field of medical devices, but I think it's the only way to really understand whether devices do really differentiate in their performance. I think I want to show you here some slides on the first head-to-head randomized clinical trial which we initiated as an investigator-initiated study. We basically looked at two devices. A new device which is currently used in Europe, the Ranger paclitaxel-coated balloon. It's the Boston Scientific technology. It's not yet approved here in the United States. What's specific about this is the coating. It uses here a cofactor, which is difficult to read actually. But most importantly, it uses paclitaxel in a very low dose density, only 2 micrograms per square millimeter. So in a way a little bit similar to the Stellarex device also. Of course the question is whether such a low dose device can perform equally well and then higher dose devices, and that's why we compared it to clearly one of the market leading devices, the impact coated DCB from Medtronic, which, as you all know, uses a dose density of about 3.5 microgram per square millimeters. As I mentioned, it's an investigator-initiated trial funded through a research grant from Boston Scientific. Again, we had independent core lab for angio and duplexes and full monitoring and the clinical events committee. The study design, again, randomized 1-to-1. Initially, we conducted a pilot study of 150 patients, and then we could extend by raising additional funding to a full cohort of 414 to further test a formal non-inferiority hypothesis. Follow-up is conducted out to 2 years, and what I can currently show you is the protocol pre-specified interim analysis of the first 150 patients, which we had presented at the Link meeting this year. Well, these were the 15 sites in Germany which we enrolled for the pilot phase of this study. We enrolled rather for 2 to 4 patients. Again, we thought we want to make it as real world as possible, lesion lengths up to 30 centimeter enrolled. And because it worked very well in the real PTX study, we again stratified in the 3 groups to ensure that really we also have a significant number of longer lesions in the study. I think this is where what we also achieved. I want to show you that in a minute. Study endpoints, very much in line with other DCB studies. Primary efficacy endpoint, this is what I also want to show you today, was really patency rate after 12 months, defined as absence of clinically driven TLR or duplex-based restenosis with the typical PVR cutoff at more than 2.4. These are other secondary endpoints which were also looked at. Here's the randomization scheme. as you can see here, 1-to-1 randomization, and then I think again a good retention of the patients to the 12 months follow-up time point. If you look at the baseline demographics, I think there is nothing too specific. We had about 35% diabetic patients, majority of patients Rutherford 2 and 3, and a few patients with rest pain. Otherwise, CLI patients, Rutherford 5 and 6, were excluded, as it was done in all other DCB studies. The target lesion length in this pilot study is around 12 centimeters. I think that will, in the future, increase because the short lesion groups enrolled somewhat faster than the long lesion groups, so there will be in the full data set probably again a lesion length more like around 15 centimeters expected, but for the time being in a pilot study we had 12 centimeters. Percentage of total occlusions in a range between 40 and 45%, as you can see here. And you can see also that the number of lesions were classified as moderately severely calcified or severely calcified by the core lab. What about bailout stent placement? Again, you can see here that the percentage was around 25%. I think in the expected range for this real-world cohort, and probably also reflecting a somewhat real-world usage of bailout stenting in the context of DCBs nowadays. So this is the slide showing the primary endpoint at the 12 months time point. And you can see that so far really the curves out to 1 year do overlap very nicely in a way, kind of supporting that with our non-inferiority intention, we are probably on the right way. You can see here that beyond 1 year, there are even some more events here in the impact group, which is probably also due to the fact that we had some patients here later on during the follow-up window. So essentially, I think we can say that at 1 year, really there is no statistically detectable difference between the two groups. So in summary, this is the first head-to-head comparison of two DCBs really done in one randomized prospective clinical trial. I think we need to see more of that. It is a real-world lesion subset with lesion lengths around 12 centimeters and a high proportion of CTOs. Really excellent efficacy results of DCB, of both DCBs, have been shown at 1 year here in both studies, and I think we can say that so far the low-dose approach of the Ranger DCB seems to work equally well compared to a higher-dose approach, which is established. The recruitment of the full cohort will be finished Q2, I would say maybe Q3 2018, so hopefully we can result them by link 2020 in January, I hope. Okay, thank you very much.